right, welcome back. Well, let's wrap up our critical care symposium today with an outstanding speaker. Once again, another good friend and an outstanding, stellar EM/IM critical care physician, Dr. Cami Hu. Cami completed our EM/IM critical care program. We were very fortunate to keep her on faculty here with us at University of Maryland, where she does split her time between the MICU and the ED. She is also our program director for the program she finished, the EM/IM critical care program, as well as our combined EM/IM program. She has really done a tremendous job leading several efforts. She leads our ED resuscitation committee, and I'm so looking forward to this talk about extubating in the ED. Many years ago, especially during my training, not really something we would talk about because at that time ED flow, well, was better. And as we've continued to have increasing boarding times, it may come as for your patients to a point where the etiology for which they were intubated has resolved and they no longer need mechanical ventilation. And in those cases, it doesn't make sense to keep patients ventilated, thereby placing them at increased risk for harm and ventilator-induced lung injury. So with that, Cami, can you help us through a safe way to liberate our patients from mechanical ventilation?
Well, thank you, Dr. Winters, for the very nice introduction. Hello, everybody. I'm Cami Hu. I'm going to try to get us a little bit caught up in time here, but I think we're back on track. You've had a lot of excellent lectures today and education on how to optimize mechanical ventilation, and what I'm going to do is try to tell you how to get rid of it in the very specific population in which it's safe to do so. Starting off, I have no conflicts of interest. We'll start with the survey. So, how do you personally feel about emergency physician-managed ED extubations? Is this something that you're like, what? I've never heard about this. This is not my job. My job is to intubate, not extubate. You feel pretty comfortable. What are your thoughts? Should I backtrack? All right, so let's get back into it. A more appropriate starter survey question: how often do you find yourself caring for a patient who is intubated in your emergency department, boarding because they don't have a ready and available ICU bed? And I don't know about you, Dr. Winters has already mentioned that this is something that we have had happen more frequently here at the University of Maryland. We are a critical care, heavy tertiary referral center, as many academic facilities are, and so we bring in lots of patients from outside institutions. That's great for them, but we do run into issues with boarding in our ED, and so we've definitely had a lot more interaction with these patients as time has gone on. That's okay. You guys will keep in mind whether or not this is something that you have to deal with. And if you're not dealing with it now, you're incredibly lucky. I'm a little bit jealous, although I do appreciate giving critical care all the time. It's my interest. But if it is something that you find happening to you frequently, hopefully this talk will be helpful in making you feel more comfortable extubating patients who no longer require intubation. So whether you're at this low end of the spectrum where you're like, I'm not interested in this whatsoever, or if it's something that you're really comfortable with, hopefully you have something that you can take away from the talk today. All right, so our to-do list today, we're going to talk about why we should, as emergency providers, have ED extubations on our radar and why we should be comfortable with doing it. We'll talk about which patients who are boarding in our ICU should be evaluated for potential extubation. We'll talk about what criteria they need to fulfill in order for us to pull that trigger and take that tube out. And we'll talk about how to actually do it with the nuts and bolts. And if we have time, we'll do questions, but we'll also have the question and answer session afterwards if there's anything lingering after the talk. So imagine it's a Tuesday shift, kind of busy. The charge nurse pulls you aside to a room quickly and says, I need you to see this patient. She's hemodynamically stable, vital signs are good, but she mentions that she started to have some swelling today and she feels like it's getting worse. As she's talking to you, she's kind of got this clearing of her throat ongoing, and mentions that she happens to be on a medication called lisinopril. So you decide, rightfully so, that you're going to protect this woman's airway from impending obstruction. And when you take a look with the laryngoscope, this is what you see. So signs of posterior airway edema, you see some edematous arytenoids and vocal cords, and although it gets a little hairy there, you're quite skilled, you're able to intubate this patient successfully without any decompensations or peri-intubation cardiac arrest, and it's high fives all around. You call the ICU, you say you have a patient who needs a bed, and they say, absolutely, we accept them, we just don't have a bed right now. So, as your shift goes on, you're hearing things from your charge nurse, and it's seeming more and more like maybe that patient's not gonna get a bed on your shift. So why is this something that we need to be aware of and need to become familiar with? Well, as we've discussed already, ED boarding is becoming a bigger problem. The rates of ED boarding are increasing. Our patient continues to be an older population. As things like obesity and regular comorbidities increase in prevalence, our patients are becoming sicker, so we're having more critical care patients come through our emergency departments. And then, of course, with the state of our economy and the health system the way that it is, we in the emergency department remain a huge safety net for patients of all kinds who require access to the medical system. So our numbers in the emergency department are increasing, our patients are getting sicker, but the ICU beds are not increasing commensurate with that need. When you look at patients who are intubated and boarding in the emergency department, we know, based on literature, that they generally do worse. They have less protective lung ventilation applied to them. They generally have increased number of days on the ventilator, and they have an increased mortality. And now you may say, well, sure, but these patients who are having increased mortality, those are the sicker patients, right? Those are the ones who are critically ill, not necessarily the ones who are just intubated for airway protection. Okay, but there are still secondary complications that come with intubation, right? With having an endotracheal tube in your airway. And that's laryngeal injury, so tracheal ulcerations, tracheal stenosis, secondary vocal cord dysfunction, speech issues, infections, whether those are ventilated-associated pneumonias, tracheobronchitis, sinusitis. There's the increased resource utilization we've already mentioned, right? So that patient in your ED bed is a patient in the waiting room who might be having an MI that you can't evaluate. Or if that patient ends up going to the ICU, it is a bed that's being taken away from somebody who is potentially really critically ill for somebody who just needs airway protection. And then we don't always consider this, but we really should. ICU stays are expensive, and as I've already mentioned, we know that healthcare costs can be debilitating for some patients. So if we can extubate the patients who deserve it, who are ready for it in the emergency department, and avoid adding that cost to their life burden, I think that's a reasonable thing for us to do and something we should be mindful of. And the limited amount of papers that have been published on this indicate that ED extubations work. They do what we want them to do. They decrease the number of patients you need to admit to the ICU. They decrease the number of patients you need to end up admitting to the hospital. And they're successful. The reintubation rates are really low. So to look at one of these, this is an analysis of 200 patients that were extubated in an emergency department over a 4-year period. And out of the 100% of patients who would have required an ICU because they were intubated, after extubation, only 7% required ICU admission. 44% were able to be discharged from the emergency department, and only 0.5%, so one patient out of the 200 or so, required reintubation. Now, I will acknowledge that this was done in a critical care area of this emergency department at this hospital, but you'll note that 56% of these patients who were extubated under the care of an emergency physician who was not critically care trained. So this is something that's perfectly feasible and safe for us to do in our emergency department, provided we select the correct patients. So who are those correct patients? Who should we be looking at and saying, maybe we could extubate you? So again, something like our initial case, angioedema without anaphylactic shock. That patient comes in, they clearly have a need for airway protection, but if they're in our emergency department long enough and they are still sitting around without an identifiable ICU bed and that airway edema resolves, these are definitely patients that we could consider for extubation. This guy, right? He's got a head trauma. Who knows what other kind of trauma? Because he's so combative, we can't actually effectively evaluate him and rule out any other injuries or head bleeds. So he's going to get put down. He's going to get sedated and intubated. But after we do our workup, if everything's fine and he's no longer agitated from whatever intoxicant may be on board, he's somebody who we might otherwise discharge if he hadn't required intubation in the first place. So somebody else that we should consider. Intoxication. So if we can't reverse it with Narcan and their GCS is low enough and they're not protecting their airway, certainly they'll get some plastic in the trachea. But after that intoxication wears off, these are the patients who would otherwise, maybe day in, day out, sober up on a hallway cot and get extubated the next day. And the only thing that's keeping them in your emergency department and slated for the ICU is the fact that this time they needed to be intubated. Once that intoxication wears off, definitely somebody who we should be thinking about extubating in our emergency department. And then non-invasive ventilation, CPAP, BiPAP, has been phenomenal in decreasing the need for intubation in these patients who come in with flash pulmonary edema for hypertensive emergency, for example. But there are patients, and we've all run into them, who are too hypoxic, too agitated, or too claustrophobic to really tolerate or cooperate with the mask that's needed for the non-invasive. And in these instances, they may require intubation. Again, boarding rates are different at different hospitals, but it's not uncommon in our institution where these patients will be managed, we'll have them on an initial drip, and they'll still be in an emergency department several hours later when we're transitioning to oral hypertensive. We've diuresed them or they've received dialysis or whatever needs to happen, and they're actually quite stable except for the fact that they have an airway in. So these are also patients who, with rapid improvement and addressing of the initial circumstance that brought them in, could potentially be patients we extubate in the emergency department. And then perhaps sort of a different setting, but patients we should 100% consider are the patients that we extubate for compassionate reasons. Clearly, we intubate patients who are in extremis who will die if we don't, and we don't necessarily know what their end-of-life goals are. We don't know what their illness is or their prognosis or what they would want for themselves. But if we discover later or it is addressed later that the goal should be primarily comfort and quality of life over quantity, then these are patients who we should try to honor their wishes and move towards compassionate extubation. So we've identified a few patients that we could look at and say, maybe we can extubate. So what are the criteria that they need to meet? Well, clearly, whatever it was that made us intubate them needs to have resolved. So these are patients who need to be awake and alert, able to follow commands. Their airway needs to be open and patent, no longer with any edema or concerns about airway protection. And they need to be hemodynamically stable. You're not trying to extubate somebody who is hypotensive or septic, for example. They need to be breathing on their own with really good oxygenation and ventilation with minimal ventilator support. And so what is that exactly? What is minimal ventilator support? Well, I'm going to backtrack us a little here. If you think about room air being 21% of FiO2, and about 4% per liter, is there a way to pause this? Mm-hmm. Or I'll just talk much faster. That's okay. Then these patients that we're extubating, we don't really want to extubate marginal patients. We want to extubate patients who are going to do well and oxygenate well on 4 liters of nasal cannula or less, room air if needed. Not patients who are going to be maybe a little bit heady, maybe require 6 liters, for example. So we want patients who are oxygenating well, a SAT of 94% or greater on an FiO2 of less than or equal 40%. Similarly, they should be able to oxygenate on a PEEP of equal to or less than 8, so minimal PEEP. Generally, we say minimal PEEP is 5, but there will be patients, especially if they have a larger abdominal girth or that presses up on that diaphragm, that require a little bit more of PEEP in order to keep those alveoli open when they're breathing on the ventilator. They need to be able to take in good tidal volumes, breathe in good breaths, so at least 5 mLs per kg, and they need to be able to do that on minimal pressure support, so with the ventilator not offering them a lot of help in taking in those breaths. So if your patient meets those criteria, minimal ventilator support, they're awake and able to interact. So these are patients who may have previously been on sedation that you've been able to wean and get them to the point where they can look at you, interact with you, follow commands. If they have a good cough and gag, they're hemodynamically stable, and they've resolved whatever it was that brought them in for intubation, they're ready for a spontaneous breathing trial. Now, there are several different ways to perform a spontaneous breathing trial with different settings. And so you may hear of different ones in the literature or the ICU. These patients that we're selecting are patients who have, again, generally no primary pulmonary pathology lending to their intubation and who have been intubated for a short period of time. So the standard SBT, spontaneous breathing trial, of 5/5 or 5 of pressure support over a PEEP of 5 for 30 minutes is going to be generally okay for all of these patients. And one of the best ways and most objective ways for us to evaluate how they've done on that SBT is the RISB, the Rapid Shallow Breathing Index. It's a good predictor of successful extubation. And what we look at is the RISB, which is the respiratory rate over their tidal volume inspired. The RISB of less than 105 after 30 minutes of an SBT 5/5 is predictive of a successful extubation, meaning that patient's not going to fail and need to require reintubation. The RISB is very good in terms of positive predictive value. So if they pass, if their RISB is less than 105, they're likely to succeed. It's a little bit less accurate in terms of negative predictive value. So if your RISB is higher than 105, it doesn't necessarily mean that you'll fail. And again, we don't take the RISB by itself. We look at all the other factors of the patient, and we are very specifically selecting a low-risk patient population to extubate in our emergency department. You don't have to remember the formula. There is an MDcalc for that. So you can simply go to your ventilator, find out what the respiratory rate is, and look at the VTI, so the inspired tidal volume there, and plug those into your calculator. So we'll say 16 and 540, and that will give you a RISB of 30. So well under our 105. So again, provided that this patient remained hemodynamically stable, they weren't super tachycardic, they weren't hypertensive, and they met all of the other criteria, if this is your RISB after 30 minutes of an SBT, this patient is likely to do well. Well, so hold up. Before we extubate these patients, do we need to check for a cuff leak? For those who may be a little bit less familiar, a cuff leak is when you deflate the endotracheal tube balloon to determine whether or not air is able to pass around the outside of the balloon between the endotracheal tube and the trachea itself. And theoretically, what that implies is that there's enough airway space there. And what people get concerned about is that if there's not a cuff leak, that the airway is still tight around the endotracheal tube and you may end up with postexpiratory stridor. But really, the data is not super great that that is a thing. What we see is that the rate of post-extubation stridor is actually pretty low. And when it does occur, it's really in those patients who required multiple attempts at intubation, so they had a decent amount of trauma causing inflammation and edema, or patients who've been intubated for a lot longer. And then what we also see is the presence or absence of a cuff leak doesn't necessarily predict whether or not post-extubation stridor will occur. So if there is a cuff leak, it doesn't mean that it won't happen. And if there isn't a cuff leak, it doesn't mean that you can't extubate the patient. So I would say for all comers, especially ones who were just intubated for airway protection, and it was a pretty simple intubation, I don't necessarily think a cuff leak is going to change your management at all or really guide you well. But for specific patients, such as this guy, who definitely had airway edema when you intubated, and you're going to want to make sure that that has abated, if you check a cuff leak, these are somebody I would check a cuff leak in, and if they didn't have one, you're not noticing any air movement around the tube, you're not seeing a difference between your inspiratory and expiratory tidal volumes on the ventilator, this is somebody who honestly, I'm going to say, let's give them 10 of IV Decadron and sit on it. I'm going to let this patient, stay intubated for another 4 to 6 hours and maybe reevaluate at that time, or take that ICU bed when it comes available. There is nobody who is going to fault you for keeping this patient intubated if their initial reason for intubation was airway edema and they don't have a cuff leak when you check. Potential roadblock on our path to extubation in patients in general. And that can be the difficulty in titrating sedation to perform an SBT. So as we've mentioned, these patients initially are started on an analgo sedation, and you're going to want to wean that sedation to off, ideally, in order to be able to remove the respiratory depressant effects and see how they do on an SBT. There are certainly patients who we have difficulty with sometimes. These may be patients who have a history of psychosis, a history of substance abuse disorder, or are on chronic benzos or opiates for pain management. And you'll find sometimes that as you're trying to wean the sedation, they just get too restless and agitated to seem safe. You're worried they may prematurely extubate themselves, they may pull out lines that may be needed, and so it can be really difficult to determine whether or not they're going to be somebody that can be extubated. Well, the one thing I'll say at the start is if you don't feel comfortable extubating this patient, that's okay. This is something that we have to deal with in the ICU as well, patients who are sort of trying to titrate the sedation to get them extubated, but agitation is a problem. But I will offer that there are some things that you can potentially use to help smooth out that sedation while weaning off the propofol and the fentanyl that may have that respiratory depressing effect. And the general classes right here, dexmetamine, ketamine, and your antipsychotics. Now, these are all not created equally. And so certainly if your patient has a primarily psychiatric reason for their agitation and needing intubation, I think the use of an antipsychotic, whether that's Haldol or Risperdal or whatever, will be helpful in your overall management. But I would not be surprised if a single dose of an antipsychotic didn't really achieve the nice smooth sedation that you need, didn't allow you to wean off the propofol entirely, et cetera, to be able to achieve an SBT. We are much more familiar in the emergency department with ketamine as a moderate sedation medication, right? It doesn't have that respiratory depressant effect at appropriate doses. It can provide some analgesia. It's hemodynamically stable. But what I will say is that as a whole in the medical field, most people and nurses, right? The nurses are going to be the people who are titrating these medications for you and actually interacting with the patients are much less comfortable or familiar with managing ketamine as a continuous infusion. So you really have to be mindful that you put this patient on a ketamine infusion, you may put them in the K-hole, and that can limit your ways to get them SBT'd and appropriately extubated. You have to deal with potential emergence reactions, and certainly I think using a medication that everybody's familiar with is a safer way to go, especially when you're instituting these extubation protocols in your emergency department. So as you can see, I sort of lean towards Precedex. Dexmetamine, Dr. Martinelli spoke about this earlier in its use. The nice thing about Precedex is it is titratable. There's a range of dosing that is appropriate for infusions, and it is not a respiratory depressant per se. So frequently in the ICU, if I run into this issue where I can't get the patient off of propofol, I can't get them safely weaned off because they're too agitated, what I'll do is I'll start them on Precedex and then achieve some sedation while weaning off the propofol that does depress their respiratory drive. And if they do well and they pass their SBT, you can extubate on Precedex because it does not suppress their respiratory drive. So it's a really nice adjunct. Again, if these patients are really agitated and you don't feel safe, this is not necessarily something you have to push for, but I find that dexmetamine can be pretty helpful when you're trying to get a patient extubated who you think will fly, but you just can't get them to not be agitated and cooperate. So moving towards the nuts and bolts of how. Your respiratory therapists will be familiar with this, but I do think that it's helpful for us as physicians to sort of know exactly how it goes. You'll need to have a few things ready at hand. So a Chuck's pad, right, to catch that ET tube when it comes out with all of the secretions. You'll definitely need to have suction ready for oral suctioning. The inline suction will be present, but it is a key part of the prep for extubation, suctioning that inline endotracheal tube and making sure it's clear. You'll want to have nasal cannula handy. And then, again, I'll say we are picking a very specific population that's going to likely do well with extubation. But I like to have the intubation box around to ward off evil spirits, and also in those rare instances where something goes awry and the patient does need to be re-intubated. So this is an example of a patient being extubated in the ICU. To be fair, you'll notice a few things. You'll need to sit the patient up. This patient could actually probably be sit up a little bit farther, but they have the Chuck's pad there and ready to go. They have already performed inline suctionings with a couple of passes to clear out the endotracheal tube, and they've already performed oral suctioning with the yank hour. And what you do when you do that is you're really going back into the posterior oral area in order to try to get any pooled secretions that may, once you deflate the cuff, if you don't suction them out, drop into the lungs, and that's really not what you want. So they're removing the tape or the Hollister, whatever you use. They're getting ready to deflate the cuff. And what you'll do is you will tell the patient to take a deep breath in, and then as they are exhaling, you'll tell them to cough, and that tube will come out. And you'll see it comes out very quickly. There's no need to prolong it, make it more uncomfortable for the patient, and you certainly don't want to initiate their gag reflex so that they're vomiting. So that tube comes out quickly. You offer them the suction to help, they can certainly manage that themselves in case there's anything else that comes up when they cough, and then the addition of nasal cannula. I think standard, there's no real evidence on this. We provide, 2 liters, 4 liters, whatever, depending on what the patient has required in terms of FiO2, but you can quickly wean this off if it's not needed. Now, after you extubate a patient, we generally watch them for about an hour. There's no data on that either, because there hasn't been a lot published about ED extubations, but it seems reasonable that you should monitor them for about an hour after they get extubated at a minimum. And one of the things that you're looking for is post-extubation stridor. So once you extubate the patient, you're going to take a listen, see if you hear any stridor right off the bat, make sure their lungs are clear. But if post-extubation stridor does occur, it generally occurs quickly after extubation and usually within the first hour. If it happens, you're going to treat them with IV steroids, so whether it's 10 of Decadron or 60 of methylpred, and you're going to nebulize racemic epinephrine. You can, in some patients, temporize this with these measures. Some of them may require non-invasive ventilation just to kind of get through it, but some patients may be so severe that they require reintubation. The data we have on this is mostly from prolonged intubations in the ICU, not so much from our ED counterparts. And so transitioning a little bit to patients who are going to be extubated, not because they're all better, but because we're focusing on a different goal, is our compassionate extubations. Now, there are going to be 2 different scenarios. There's going to be the patient who comes in and required intubation for something that's probably relatively rapidly reversible, right? Our terminally ill patients can have asthma or COPD exacerbations. They can have volume overload from cardiogenic pulmonary edema. And so if it's within their goals of care to receive something like non-invasive or high-flow nasal cannula, you can extubate to those measures in order to temporize them, continue ongoing therapy, and they may actually improve. Based on surveys, we know that they have improved comfort with these measures over nasal cannula, that in non-invasive for these rapidly reversible issues, they actually do have a decent amount of hospital survival. And with high-flow nasal cannula, if necessary, in these patients who have a little bit more respiratory distress, you improve their hypoxia and stave off the need for non-invasive. In those other patients, where actually the patient is terminal, there's been a catastrophic event, or the primary patient or family focus is just quality and palliative care, it's important that we focus on their comfort. And the main thing that you don't want to do is take a patient who required full respiratory support, they came in respiratory distress, and then extubate them before we've ensured that that respiratory distress and that air hunger and that discomfort won't recur as soon as the tube is removed. So the big thing is to, in stepwise fashion, wean your ventilator settings while you titrate your meds to comfort. And what this means is essentially gradually decreasing the amount of pressure support you provide, tidal volumes you provide, and see how the patient responds. And so if you need to, with your opiate infusion, if they're not able to tell you about pain or air hunger because they're altered or whatnot, a respiratory rate of 12 to 14 is a reasonable titration goal. You're going to provide them with benzodiazepines, IV PRN, not so much an infusion, for air hunger or for anxiolysis. And then in patients who have secretions, you should certainly provide IV anticholinergics, so glycopyrrolate or atropine for secretions. You really want to prevent that sense that they're not able to clear their airway, and you want to prevent that raspy rattle that can be so distressing for the patients and also their families. So what I generally do is I will gradually wean my pressure support down to 0 for these patients as I make sure at each stepwise fashion, either whether it's 2 of pressure support, that we're still titrating meds, they still look comfortable, they don't look like they're gasping or sucking for air, and that it's going to go well when that tube gets removed. So at this point, I think I'll check in on time. If we have any time for some questions before I hit the take-home points, if there are any.
All right. So a couple of questions here. So for your normal patient, when you're doing an SBT, do you keep them on some sedation like propofol, fentanyl? Do you turn them completely off? Or do you do something in between to keep them comfortable?
So that's a good question. I didn't directly dedicate a slide to this, but ideally the goal in these patients who no longer require intubation is that they're no longer going to require sedation as well. So in general, a wean, there's no hard and fast way to do this. Some nursing protocols, depending on what hospital you work at, will sort of delineate, 10 of propofol per, however many minutes or an hour. But just a slow wean to off if you can. And so Ashley mentioned earlier, fentanyl infusions are not totally necessary in most patients, so I like to get rid of that one right off the bat if we can. And you can still provide IV boluses as needed for pain control, but really weaning that propofol to off is ideal. And then there are those instances where as you wean the propofol, their sedation, the agitation really comes out. And those are the instances in which I will generally transition to Precedex if I think an antipsychotic's not really going to cover what their need is. That target all those questions.
Yeah.
Yeah.
So, and then another question is, is there any role for getting like a gas during or after an SPT?
So the answer is maybe. Often in the ICU, this is something that we talk about. For your patients specifically, I would never discourage a gas, but I would say that these are patients whose pulmonary function is good, right? They weren't intubated because they had an asthma exacerbation. They weren't intubated because of, a pneumonia or anything. Their pulmonary function is quite good, and it's not a primary pulmonary issue. So in general, if you're minimizing your vent settings, you're minimizing your sedation, and you're letting them sort of breathe on their own as they would, a gas isn't usually necessary for a patient who was just intubated for airway protection per se. Okay, so only a couple of take-home points here. First one is that appropriately screened patients. So we're picking the cream of the crop so that we can proceed with safe extubation. As long as they don't need that initial intubation need has gone away, they can be safely extubated in the emergency department. In these patients, stable vital signs, so no crazy tachycardia or hypertension, and a RISB of less than 105 on an SPT for 30 minutes of 5/5 signals that they will be a successful extubation. And then compassionate extubation is something that we should absolutely pursue for our patients whose primary goal is comfort. Okay.